I don't know, it's good morning or good afternoon. Yeah, it's good morning. So, we are going to start a very important part of the medicinal education, that is pharmacology. It's also a very important part of medical education, and that's pharmacology. And we are going to start that pharmacology today. Okay, so we have to complete that general pharmacology anyhow today only. Am I clear? So let's start with the very basic combined drug effects. Okay, so by mixing of drugs we can see the following effects, and the following effects are addictive effects, synergistic effect, and antagonistic effect. So what are additive effect? In this additive effect, the effect of the drug will be same as before, and it will be same in the after their combination also. So if a drug A has its effect, individual effect, if a drug B has its individual effect, then if we combine both the drugs, after that, after the combination of drugs, still they will show their still they will show their uh, similar effect, and the strength of the effect will be as usual as earlier, individual effect. So A as usual, B. Okay, so you will get that A effect and B effect. What does it means? The effect of A and the effect of B before the combination, and the effect of A and the effect of B after the combination or mixing, all will be same. Okay, after that, next important thing, we will see the each and every concepts little bit deep. So first of all, additive effect. So in this additive effect, what will happen? The combined drugs produces effect equals, the combined drugs produces effect equals to the individual effect, equals to combined drug. Combined drug means when both A and B are combined, they will show the effect which is equals to the which is equals to the individual effect. See, the drug A has its individual effect A, the drug B has its individual effect B, but when both the drugs A and B are combined, still they will show the effect like A and B. So the effect of A plus B is equals to the effect of A plus effect of B. So this is called additive effect. For example, you can see metformin and glimepiride. So when metformin and glimepiride both are taken together, there is no effect or no contraindication. Both will see there is no drug interaction. Both will show their individual effects. So in that case, metformin will show the anti-diabetic effect without any problem. Next, you can take propranolol along with nifedipine. This propranolol is an antihypertensive drug. So when you will take it with nifedipine, there is no problem. It will show the antihypertensive effect. Next is paracetamol. Paracetamol is antipyretics. When you will take it with ibuprofen, it will not show any. The effect of the drug will not be changed, and it will show the similar effect, antipyretic effect. Okay. Next, the drug is halothane. When you will take halothane along with ketamine, there will be no problem in general anesthetic property of the halothane. So halothane will definitely show the general anesthetic property. Okay. Next, synergistic effect. In that case, what will happen? The combined effect of the drug will be more than the individual effect. The combined effect of the drug will be more than the individual effect. See, this is the drug A, drug B, and this is combined drug A plus B. So combined drug has more effect than the individual effect. See, if combined drug effect is greater than the individual effect, the drugs on combination is called synergistic effect. So what does it means? The when the drug is taken together, and it will show more effect than when the drug is taken individual. This is individual, this is individual. At that time, this is called synergistic effect. And that, for example, see here, drug A has its own effect and drug B has its own effect. But when both the drug A and B are taken together in combination, So drug A plus B has more effect than drug A and drug B. So drug A plus B has more effect than effect of drug A and effect of drug B. Example is tyramine and MAO inhibitor. Example is tyramine and MAO inhibitor. What is that MAO inhibitor? MAO inhibitor is called monoamino oxidase inhibitor. Monoamino oxidase is an enzyme which is mainly its main function is to metabolite or to metabolism. Its main function is metabolism. So when the MAO monoamino oxidase level will increase, it will also show more metabolism, and when more metabolism will be there, less drug will be there in the body, so it will show ultimately less effect. But when less MAO enzyme is there, that means less monoamino oxidase enzyme is there, it will show less metabolism. It will automatically reduce the metabolism. Why? Because enzyme is less, not as usual as earlier. So since the metabolism will decrease, the drug will be more in the body, and when the drug will more in the body, it will show more effect. Okay, so MAO is a very important metabolic enzyme, which is if we decrease that MAO, see here MAO inhibitor is there. So MAO inhibitor means you can take any drugs which are MAO inhibitor. For example, physostigmine also. No, physostigmine is cholinesterase inhibitor. So you can take any MAO inhibitor. So if you take that MAO monoamine oxidase inhibitor, it will cause a decrease in the monoamine oxidase enzyme. When monoamine oxidase enzyme will decrease, the metabolism of tyramine will also decrease. So when metabolism of tyramine will decrease, the what will happen, that noradrenaline level will increase. When noradrenaline level will increase, blood pressure will definitely increase. Why? Noradrenaline level will increase in vascular smooth muscle. Vascular smooth muscle contraction will increase. When vascular smooth muscle contraction will increase, vasoconstriction will take place, and when vasoconstriction will take place, the blood pressure will be high. Okay, next I want to tell you is that next example is sulfamethoxazole along with trimethoprim. When you will take sulfamethoxazole along with trimethoprim, any antimicrobial effect will be seen, and it will show more antimicrobial effect. Next is tricyclic antidepressant and cocaine. So when you will take tricyclic antidepressant along with the cocaine, it will also cause the increase in noradrenaline level, and when noradrenaline level will increase, blood pressure will also increase. Next is acetylcholine and neostigmine. So when you will take acetylcholine along with the neostigmine, it will ultimately increase the acetylcholine level, and when acetylcholine level will increase, the muscular spasm you will see. Why muscular spasm? Due to the muscarinic receptor activation. So acetylcholine will bind there, and after binding of that, what will happen? Muscular spasm or muscle spasm will increase. Okay, next antagonistic effect. Antagonistic effect means when you are taking the individual drug, it will have its individual effect. When you are taking another individual drug B, it will have another individual effect, its own individual effect. But when you will take both the drug A plus B in combination, it will have less effect. So why it will happen? Either due to the antagonism this will happen. So what are the different types of antagonism may takes place here? Either chemical antagonism, one drug will bind with another drug and they will decrease the reactivity. Next is pharmacokinetic antagonism. This drug will decrease the absorption or metabolism or distribution of B, or B will decrease the absorption, distribution, metabolism of A. Anything can happen. So pharmacokinetic antagonism also possible. Physiological antagonism also possible. For example, if you take any drugs which is having which is having an effect of high blood pressure, that is, if this drug decreases the MAO enzyme or monoamine oxidase enzyme, or it can anyhow it can increase the noradrenaline level or adrenaline level, it will increase the blood pressure. Again, another along with that, if you are taking another drug which can decrease the noradrenaline level, then ultimately what will happen? Physiological changes which take place, and due to the physiological changes, physiological antagonism will be seen. In the most important, physiological antagonism is seen in the case when there is that non-selective alpha agonist is taken. So when non-selective alpha agonist is taken, what happens at that time? Alpha adrenergic receptor are two type, alpha 1 and alpha 2. Alpha 1 and alpha 2. In that case, what does this alpha 1 do? This alpha 1 increases the vascular smooth muscle contraction. Whereas what does alpha 2 does, this alpha 2 receptor, it will that neurotransmitter reuptake mechanism increases. So at that time what will happen, something neurotransmitter is released here, sir, for example noradrenaline or norepinephrine, anything is released from the vesicles here. So what will happen, the automatic reuptake mechanism will activate. This receptor is alpha 2 receptor, but alpha 1 causes a contraction of smooth muscle. So for initially smooth muscle was like this, but after that smooth muscle will be like this. So contraction, due to contraction what will happen, vasoconstriction will take place, and due to the vasoconstriction blood pressure will increase. So this is a type of physiological antagonism. So in that case what is happening, one is increasing the blood pressure, another one is decreasing the blood pressure. So ultimately blood pressure will neither increase nor decrease, it will be in a mixed situation. Next is antagonism due to the receptor blockage. Okay, so first we complete that. So this is called antagonistic effect. Antagonistic effect are one drug nullifies the effect of the other drug. Nullifies means it will cut the action. Cut means it will cancel the action. So one drug will nullify the effect of the other drug. So this nullify is important. So if one drug nullifies the effect of the another drug, it is called antagonistic effect. It is called antagonistic effect. There are four types of antagonism, and they are chemicals, just I have mentioned. They are chemical antagonism, pharmacokinetic antagonism, physiological antagonism, antagonism by receptor blockage. These antagonism by receptor blockage again are of two types. One is competitive antagonism, one is non-competitive antagonism. Competitive antagonism is possible in two cases. Number one, if both the antagonists are having similar chemical structure. If both the antagonists are having or if both the ligands, or if both the chemicals or both the drugs are having both the enzymes, both the hormones are having similar and chemical structure, then that competitive antagonism also takes place. And number two, if both the antagonists are binding to the same receptor, then also competitive antagonism will takes place. Okay, and non-competitive antagonism is also there. In that case they will not have similar structure, but one will bind with the one side, another one antagonist will bind with one side, or one ligand will bind at one side, but another ligand will bind at the another side. So there is no competitive antagonism at that case. Now the most important thing that we are going to learn is that different chemical antagonism, and we will see the different types of antagonism now. So what are the different types of antagonism possible? They are chemical antagonism. Please repeat after me loudly. What are they? They are chemical antagonism, they are pharmacokinetic antagonism, they are physiological antagonism, they are antagonism by receptor blockage. Antagonism by receptor blockage is again of two types. They are non-competitive and competitive antagonism. Okay, competitive antagonism takes place in which case? In the case if both the antagonists are similar in structure, and both the antagonists are binding on the same site. Okay, next, what are the chemical antagonism? Decreases the effect of the drug due to the chemical reaction between the drugs. I have mentioned earlier in that case only, that antagonism case. In that case I have mentioned about this only, that due to chemical reaction what will happen, the drug action or drug effect will be decreased. So this is known as chemical antagonism. This is simply called chemical antagonism. In that case what will happen, chemical reaction between the drugs will takes place. The examples of the chemical antagonism are atropine and physostigmine. Atropine and physostigmine. In that case atropine increases the atropine toxicity, or it is poisoning. If toxicity increases, then if you supply physostigmine at that time in the body, or introduce physostigmine in the body, then what will happen, the atropine toxicity will be decreased, or it will be treated very easily. Next, tannins or tannins plus toxin, which is treated normally with the activated charcoal. Next, lead toxicity is treated with succimer. Now I forgot to tell you one thing, I forgot to mention that this chemical antagonism are mainly used in the case of toxicity treatment. Any types of any chemical toxicity treatment, in that case mainly chemical antagonism are used. Okay, so what are they? Next, lead toxicity being treated with succimer, and next, cyanide toxicity being treated with sodium thiosulfate or amyl nitrate. Sodium thiosulfate or amyl nitrate. Next, copper poisoning can be treated with penicillamine. Copper poisoning can be treated with penicillamine. Next, heparin can be treated with proamine sulfate. So these will show chemical antagonism. Heparin along with the proamine sulfate. Warfarin along with the vitamin K. Warfarin is an anticoagulant, whereas vitamin K is a coagulant. So when anticoagulant and coagulant both will show their effect, what will happen? Antagonism will definitely take place. The warfarin will try to show its effect as anticoagulant, and vitamin K will try to show its effect as coagulant. Next is benzodiazepines. So benzodiazepine is a barbiturate drug, okay, along with flumenazine. So barbiturate drug, what will happen? Diazepine is a sedatives or hypnotics. It is a sedatives. So when this sedative will be taken, what will happen? It will try to decrease the anxiety. But along with that, if you take flumenazine, then what will happen? This flumenazine will show antagonism along with the benzodiazepine. Next, you can take barbiturate. So barbiturate drug along with the sodium carbonate, it will show the antagonism. Next is iron. When iron is taken along with the desferoxamine, so along with the desferoxamine, what will happen? It will show antagonism. Which type of antagonism? Chemical antagonism. Next, heavy metal. Heavy metal toxicity can be treated with EDTA. What is EDTA? EDTA is ethylene diamine tetraacetate. Ethylene, wait. EDTA is ethylene diamine tetraacetate. So EDTA is ethylene diamine tetraacetate. Okay. Next, organophosphorus compound. If organophosphorus compound are taken with the prelidoxin, organophosphorus compound along with the prelidoxin, it will also show chemical antagonism. Next is pharmacokinetic antagonism. So what are the different types of pharmacokinetic antagonism? If one drug affects the ADME, that is absorption, distribution, metabolism and elimination of the another drug. So what is pharmacokinetic? It is simply the ADME only. So ADME means absorption, distribution, metabolism and elimination. So if one drug affects the ADME of the another drug, then it is called pharmacokinetic antagonism. If drug A can decrease the absorption or distribution of drug B, or ultimately what will happen? The effect of drug B will decrease. If drug B decrease the absorption or distribution of drug A, then also what will happen? Effect of drug A will decrease. Yes or no? So if it can increase the metabolism of drug A, then also what will happen? Action of drug A will decrease, or effect of drug A will decrease. Now we will see the examples. Number one is warfarin. Number one is warfarin. So see here, if warfarin is taken along with phenobarbital, then what will happen? This phenobarbital induces the metabolism, ultimately increases the metabolism of the warfarin. So why the metabolism of warfarin is increased? See, warfarin is metabolized by CYP450, and this phenobarbital increases the CYP450 enzyme. So it is called CYP450 enzyme inducer. Phenobarbital is CYP450 enzyme inducer. So when this enzyme will increase, metabolism of warfarin will increase. When metabolism of warfarin will increase, what will happen? The effect of warfarin will decrease. At that time, the effect of warfarin will decrease. So you will not see any more effect of the warfarin. Effect of warfarin will decrease due to the increase in the metabolism of warfarin. Okay. Next, if you take tetracycline along with the calcium compound, that what will happen? Compensation will takes place. Ultimately, what will happen? Decrease the absorption of the tetracyclines, and when the absorption after the tetracycline will decrease, the effect of the tetracycline will also decrease. When the absorption of the tetracycline will decrease, the effect of the tetracycline will also decrease. Next is phenytoin and NSAID. So when you will take phenytoin along with the NSAID, what is NSAID? Non-steroidal anti-inflammatory drugs. So if you take phenytoin with the NSAIDs, then also what will happen? It will decrease the distribution of either drug. It will decrease the distribution of either drug. So either phenytoin will bind to the albumin or NSAID will bind to the drug site and affect the unbound drug. The unbound drug will show its action and bound drug will go with the albumin. After albumin leaves it, it will show its effect. So ultimately what will happen, what do I want to say is that this, if you take NSAID along with the phenytoin or phenytoin along with the NSAID, then both the phenytoin and albumin binds to the both the phenytoin and NSAID binds to the albumin. So what will happen? Either phenytoin will bind or NSAID will bind. So the one which will bind, it will not show after. The ones which will release after that, it will show its effect. So ultimately, what will happen? It will decrease the distribution of the either drugs. So when the drugs is binded with the albumin, after that the distribution will takes place now. So if it is unable to bind with the albumin, there is no distribution. Okay, next probenecid and NSAID. So when you will take probenecid along with the NSAID, same what will happen, it will also decrease the excretion of the either drugs. So when the either probenecid or NSAID are excreted, so when the drug excretion of one drug will decrease, it will affect the it will affect on the effect of drug. So either it will show antagonism. Which type of antagonism? It is pharmacokinetic antagonism. Okay. Next important point is that physiological antagonism. So in that case, in physiological antagonism, drugs on combination produces opposite physiological effect. Drug on combination produces opposite physiological effect. Opposite physiological effect means one will increase, another one will decrease, like this. So it is called physiological antagonism. For example, you see histamine along with proton pump inhibitor. So if the histamine is activated, what will happen? It will increase the HCl secretion in the stomach. Along with that, if you will take proton pump inhibitor, then what will happen? It will decrease the HCl secretion in the stomach. For example, what are the example of proton pump inhibitor? They are omeprazole, pantoprazole. So when you will take either omeprazole or pantoprazole, along with that, if you take any histamine activator, or you will take immunostimulant, that what will happen? Ultimately, it will affect each other's activity. Okay, next is insulin along with glucagon. So what does insulin do? Insulin decreases the blood glucose level in the body, and along with that, if you take glucagon, then what will happen? Glucagon will increase the blood glucose level in the body. So ultimately what will happen? They will show physiological antagonism: insulin and glucagon, histamine and proton pump inhibitor, histamine and proton pump inhibitor, loop diuretics, and spironolactone. So what does spironolactone do? It decreases the potassium excretion. Spironolactone decreases the potassium excretion, whereas loop diuretics increases the potassium excretion. So loop diuretics increases the potassium excretion. What are the example of loop diuretics? They are furosemide, bumetanide, ethacranic acid. Okay, furosemide, bumetanide, ethacranic acid are the example of loop diuretics. So if you take loop diuretics along with the spironolactone, then what will happen? So loop diuretics will try to increase more potassium excretion, whereas spironolactone will decrease the potassium excretion. That's why it is important. Okay, now you have next is antagonism by receptor blockage. This is the fourth type of antagonism. So antagonism by receptor blockage are of two types. One is competitive antagonism, which is reversible, and another one is non-competitive antagonism, which is irreversible. So what is competitive antagonism? In this type of antagonism, there exists competition between agonist and antagonist. Competition between agonist and antagonist exist. So for binding to the receptor, I mentioned earlier that it will mainly takes place if both the drugs or both the ligand are having similar structure. In that case, competitive antagonism mainly takes place. Number two, if both of the drugs or both of the ligand wants to bind in the same site of the receptor, at that case also competitive antagonism takes place. Okay, like I will tell you, 10 male wants to enter and 10 female also wants to enter through the same door. then what will happen? There will be some uh, congest congested situation will be there, yes or no? So in that case competition will increase. Who wants to go fast, who wants to enter fast? So this is simply competitive antagonism. In the same way, so now agonist and antagonist bind to the receptor reversibly. You have to remember that competitive antagonism is a type of reversible antagonism. Agonist and antagonist binds to the receptor reversibly through hydrogen bonds. Through which bond? Hydrogen bond or ionic bond, or ionic bond. Okay, so they exist the structural similarity. I have mentioned 3 4 times about that structural similarity between the agonist and antagonist. So what are the main important points here? Number one, binds with the hydrogen bond or ionic bond, and next point is structural similarity is there. Next, their rightward shift of the DRC. What is DRC? DRC is the dose response curve. What is DRC? DRC is the dose response curve. So when there is any competitive antagonism, at that time what will happen? There is a rightward shift. Which type of shift? Rightward shift of the dose response curve. The curve in case of competitive antagonism is reversible. The curve in case of competitive antagonism is reversible. Next, rightward shift is denoted by dose ratio. Rightward shift is denoted by dose ratio. So what is dose ratio? Dose ratio is increase of agonist concentration upon antagonist concentration. Increase of agonist concentration upon antagonist concentration. By this way you can remember dose ratio, or you can find out the dose ratio. So what is dose ratio? Dose ratio is the increase in agonist concentration upon increase in antagonist concentration. Next, number 2 is Emax remains constant. What is Emax? Emax is the maximum rate, or it is also called saturation point, saturated. Okay, in that case all the car will be in saturation point. Okay, it is the final point. So Emax remains constant. Emax remains constant. What is Emax? It is the rate. So in this type of antagonism, intensity of response depends on both the agonist and antagonist concentration. You have to remember that. In the case of reversible antagonism, what will happen? Intensity of response depends on both the agonist and antagonist concentration. Intensity of response depends on both the agonist and antagonist concentration. Okay, so this is the graph. In that case what will happen? See, I will tell you one thing. In that case these are the agonist and these are the antagonist. So antagonist 0, 10, 100, 1000, and here agonist 0, 10, 100, 1000, like this. So when less agonist will be there, more antagonist will be binding. When little bit more antagonist will be there, less antagonist will be binding. When little bit more, less antagonist, little bit more, less antagonist. But the dose ratio will be same. Dose ratio will be same because both the increase in antagonist concentration and both the increase in agonist concentration are equal here. See the gap is equal or not? So since both the agonist concentration and the antagonist concentration, increase in agonist concentration and increase in antagonist concentration are same here, the dose response will also be equal, or dose ratio in the dose response curve. Now I'll tell you the examples. In the example you will see these are agonist and these are antagonist. So when you will take morphine along with the naloxone, it will show different competitive antagonism, and the receptor is opioid receptor. So morphine will also bind to the opioid receptor, naloxone will also bind to the opioid receptor, and they will show competitive antagonism. Next is acetylcholine. When this acetylcholine is taken with atropine, both the atropine and acetylcholine binds to the muscarinic receptor. Both the acetylcholine and atropine binds to the muscarinic receptor. So when you will take that acetylcholine along with the atropine, there will be a competitive antagonism possible. There is a possibility of competitive antagonism. Next, wait a second please. if the competitive antagonism is irreversible. In another case, if the competitive antagonism is irreversible, in that case there is an exist a competition between agonist and antagonist for binding site to the receptor. So when binding site to the receptor will be there, I mentioned that there will be two types of competitive antagonism will be in two cases. Number one case is both the structures are similar and receptor are only one. In another case, both the ligand will try to bind to the same receptor site. Okay. So both the ligand will try to bind to the same receptor. In that case, another antagonism will be there. So one is called competitive antagonism, reversible. Another one is competitive antagonism, irreversible. Okay. Now in that case, the competitive antagonism will be irreversible. In that case, what will happen? The competition will be between agonist and antagonist binding to the receptor. The competition between agonist and antagonist will be between binding to the receptor. Antagonist bind to the receptor reversibly. Antagonist bind to the receptor reversibly with a covalent bond. So when there is a reversible binding, there will be covalent bond. But when there is irreversible binding, there will be either hydrogen bond or ionic bond. Hydrogen bond or ionic bond. Next, flattening of dose response curve will takes place in this type of antagonism. So flattening of dose response curve means the dose response will be decreasing. Time to time it will decrease. Response of the drug dose will decrease after several time. So Emax decreases in that type of antagonism. Emax decreases in this type of antagonism, whereas in the case of competitive antagonism reversible, Emax will remain constant. And in the case of competitive antagonism irreversible, Emax will decrease. Next, intensity of response depends on the antagonist concentration only. Intensity of response depends on the antagonist concentration only, whereas in the case of reversible, intensity of response depends on the both agonist as well as antagonist. So here intensity of response depends on the antagonist concentration only. Next, for example, aspirin binding to COX enzyme. Aspirin binding to COX enzyme. So number two, omeprazole binding to hydrogen and proton ATPase enzyme receptor in parietal cell. Hydrogen and ATPase enzyme receptor in parietal cell. These two drugs shows competitive antagonism, but it is irreversible competitive antagonism by acting as antagonist. So you can see that when you will take aspirin and also omeprazole along with that, both will show competitive antagonism, irreversible competitive antagonism. It will show irreversible competitive antagonism. Why? See, I'll tell you. For example, this is a receptor, this is another receptor, this is our cell. One will come and bind to that, for example aspirin. It will show its effect. So aspirin is an anti-inflammatory. Whereas if you take along with that omeprazole B, it will also show its effect. Okay. So when you will stop taking omeprazole, aspirin will show its effect. But when you will up to the time you will take omeprazole, aspirin will not show its effects properly. So what will happen? Antagonism will take place. Which type of antagonism? Competitive antagonism. But this is competitive reversible antagonism or competitive irreversible antagonism. So this is irreversible competitive antagonism. Okay. Next we will see the non-competitive antagonism. So what is non-competitive antagonism? In that case, both the drug will bind to the different site of the receptor. So there is exist no competition. No competition exists between agonist and antagonist. Agonist bind to the receptor. Antagonist blocks the series of the events after the receptor activation. What will happen? When the agonist will bind to the receptor, it will start showing its effect. So to show its effect, it will have some series of responses. For example, see here, when the agonist bind to the receptor, this is the receptor. When agonist will bind to the receptor will activate, and when the receptor will activate, it will show different series 1, 2, 3. So is this visible? So these are the different series 1, 2, 3. Now what will happen? The antagonist will come and it will try to bind here, and it will try to block the series of the receptor. So this antagonist will try to block the series of event of the receptor after its binding. So ultimately what will happen? Effect will be decreased. So by this way, this antagonism, non-competitive antagonism takes place. So there is exist no competition, you have to remember in that case. And what are they? The competition is between agonist and antagonist only. Next, agonist bind to the receptor, then agonist will try to show its series of action. After that, antagonist will come and it will block the series of the event after the receptor activation. So antagonist will block the series of event only. Next, see, in that case also, the signal transduction mechanism which occurs after the agonist binding to receptor. Signal transduction mechanism which occurs after the antagonist binding to the receptor, also called as series of cellular response. It is called series of cellular response. The intensity of response depends on the antagonist concentration. If the antagonist concentration will more, the series of response will be less. If the antagonist concentration is less, the series of response will be more. So for example, see ketamine acting on the glutamate receptor as an antagonist. So in the glutamate receptor, ketamine will come and bind, and it will try to block the binding of the glutamate. Next, picrotoxin acting on the GABA receptor. Picrotoxin acting on the GABA receptor. So you have to remember ketamine acting on the glutamate receptor as an antagonist. In that case, antagonist will be ketamine. Again, picrotoxin come and it will bind to the GABA receptor. So this is an antagonist. Picrotoxin is an antagonist and it will bind to GABA receptor and it will try to lessen its activity. Picrotoxin will lessen the activity of GABA receptor. Okay. So in that case, what will happen? See, when the drug or any ligand will come and bind to the receptor, after binding to the receptor, there will be cellular effect. This cellular effect will be shown after the signal transduction mechanism. In that signal transduction mechanism, there will be series of event 1, 2, 3, 4 like this. So what will happen? In that case, the antagonist will come and it will try to come and bind here, and it will try to block this event. When it will block the event, what will happen? The event will not proceed further, and when the event will not proceed further, the cellular effect will also not seen. So this is a type of in non-competitive antagonism. See, what are the what are the four types of effects we got? The four types of effect are additive effect, next synergistic effect, next antagonistic effect. So what are the mainly three types? Additive, synergistic, antagonistic effect. These antagonistic effect are these antagonistic effect are four types. What are they? Number one is chemical antagonism, next physiological antagonism, next physical antagonism, pharmacological. Number one, chemical antagonism, next physiological antagonism, next pharmacokinetic antagonism, and next number four is, what is the number four? That is antagonism due to receptor binding. This antagonism due to receptor binding are of two type. One is competitive antagonism, one is non-competitive antagonism. This competitive antagonism, why it takes place? Due to two reasons, mainly due to two reasons. Number one reason is due to the similar structure of the antagonist and agonist, and second is due to the binding site, fighting between binding site. Okay. Next, we will see the different drug targets. What are the different drug targets? So different drug targets are: number one, receptor; number two, ion channel; next, enzyme and carrier protein. So what are the drug targets? Can you please tell me? Drug targets means when we will take any drug, where does the drug will go and it will show its effect, and where does it will bind, where does it will work, it will show its action, and finally we will get the cellular response or any type of pharmacological action. So these receptors, ion channels, enzymes and carrier proteins are the target of the drug. These receptors, ion channels, enzymes and carrier protein are the drug target, where the drug will go and bind or it will show its action after we will take the drug. So drug target are four type. What are they? Drug targets are four type. What are they? Number one is receptor, next is ion channel, next is enzyme, next is carrier protein. So by binding to the receptor, it will show its action. Number two, uh, by acting on the ion channel, it can also show its action. It by acting on the enzyme, it can also show its action, and by acting on the carrier protein, it can also show its action. So these are the four drug targets you have to remember. These are the four drug targets. Now we will see what are the different types of ion channels. So normally there are two different types of ion channel. They are voltage gated ion channel and ligand gated ion channel. So what are voltage gated ion channel? We will see after next we will see that, and like what are the ligand gated ion channel we will see. So voltage gated ion channel, in these types of ion channel what will happen, the ion channel which are operated based upon the charge present inside membrane. So in that case of voltage gated ion channel will be operated based on the charge present on the side membrane. Charge present on the side membrane means, I hope you have studied about the potential generation. So action potential, hyperpolarization, depolarization, repolarization. So this hyperpolarization, depolarization, repolarization, resting membrane potential, these all are the different types of potentials. So potential means combination of charge, not a combination of charge, these are a set of charge. Okay, so when the set of negative charge will be more on the outside the cell, the negative the outside the cell will be negatively charged, so negative potential will be there. And when the inside is positively charged, so it is called positive potential. If outside is positively charged, it is called positive potential on the outer side. At that when the positive charge is on outer side, it will be in resting membrane potential or resting phase. Now we will see that properly. So what are voltage gated ion channels? Voltage gated ion channels are those ion channels which mainly operate based on the charge present inside or outside the membrane. So mainly these are the ion channels which acts or operates based on the charge present inside the membrane. Why inside the membrane? The potential generation takes place when the positive charge is inside, more inside, or the inside of the cell membrane is more positively charged, or positive potential is present. At that time depolarization will takes place. Repolarization will takes place when the inside of the cell is negatively charged, and hyperpolarization will takes place when the inside of the charge is very negative, more and more negatively charged. So ultimately the charge present on the outside is affecting less, and the charge present inside the cell or inside the membrane is affecting more. Okay, so ultimately this voltage gated channel or voltage gated ion channel mainly affects or acts operated based on the charge present inside the membrane. So if excess positive ion inside the membrane is there, then it will show depolarization. If excess or more positive ion inside the membrane is there, it will show depolarization. If more negative ion are present, more negative charge are present, excess negative charge are present inside the membrane, then it will show repolarization. It will show repolarization. So during repolarization, less negative ions will be there. This is something else, I'll tell you. Wait. In the case of hyperpolarization, see, these repolarization and hyperpolarization are two things which are also dependent on the negative charges. If less negative charge is there, it will cause repolarization. Repolarization. If more negative charges are there, it will cause hyperpolarization, and it is approximately minus 70 or minus 30, and it is minus 90. So when minus 90 is there, it will cause hyperpolarization, minus 90 to minus 120. And when only minus 30 is there, it will cause repolarization. Okay. So what are different ligand gated ion channel? So ligand gated ion channel are the ion channel which are operated based upon the ligand binding to the ion channels. Ligand binding to the ion channels. So ion channels which operated based upon the ligand binding. Ligand means different types of drugs, different types of enzymes, different types of hormones, different types of protein, different types of uh, neurotransmitter or anything. So ultimately ligands are the drugs or hormones or chemicals. Simply you can say chemical. So ligand gated ion channels are the ion channel which operated based on the ligand binding on the ion channel. Ligand binding to the ion channel. For example, this is an ion channel. This is the cell membrane. These are the ion channel. Okay. Wait, this is a cell membrane. These are the ion channel. So when this ligand will come and bind to the receptor, it will either open or close. So if it is open, then positive charge will come inside. Okay. This is the cell membrane. These are the channel. These are the positive charge coming inside. Okay. So this is important to understand what is ligand binding. Now we will see what are the different types of ligand binding. So when ligand comes and bind to the ion channel, opening of ion channel may takes place. Opening of ion channel may takes place and entry of the positive charge or negative charge takes place. Entry of the positive ion charge or positive ion or negative ion also takes place. So see here what are the ion channels and what are their blockers. So ion channel, for example, voltage gated sodium channel can be, these voltage gated sodium channels are blocked in the case of anti-epilepsy. So it can be blocked, it is blocked mainly by the anti-epileptic drug, local anesthetics and anti-arrhythmic drugs. Why? The reason is that when the voltage gated sodium channel opens, the entry of more sodium ion, the entry of more sodium takes place. When the positively charged sodium will enter inside the cell, what will happen? More positive charge will be there inside the cell. Since more positively charged will be there inside the cell will become depolarized. So when the cell will become depolarized, it will show its contraction or any types of action. So due to that, what will happen? Due to the cell contraction, epilepsy also takes place. Due to the cell contraction, that cell activity will takes place, and when the cell is inactive, at that moment it is called anesthetic, and in that case the cell will be inactive. It will not show any activity like contraction or anything. So that's why in local anesthetic also sodium channel blockers are given. And what is antiarrhythmic? In the case of antiarrhythmia, what will happen? So the arrhythmia means it is two type. One is tachycardia, one is bradycardia. So when tachycardia takes place, more contraction of cell takes place, due to which tachycardia takes place. Yes or no? So to decrease the tachycardia or to treat the arrhythmia, tachyarrhythmia, we can block the sodium channel. Which type of sodium channel? Voltage gated sodium channel. When the voltage gated sodium channel is blocked, at that moment what will happen? There is no entry of sodium. When there is no entry of sodium, what will happen? The positive charge which were being generated inside the cell will now not generate. And when they are not generated, what will happen? The cell depolarization will not take place. The cell will not be depolarized, the cell will not be active. When the cell will not be active, not depolarized, it will not show any contraction. When the cell will not show any contraction, ultimately what will happen? Tachyarrhythmia will decrease, it will reduce, and the treatment will be done very easily. Next is voltage gated sodium channel. So voltage gated calcium channel. So what are voltage gated calcium channels? The way sodium channels are there, in this same way calcium channel will be also there. So in this through the calcium channel, entry of the calcium ion will takes place. So calcium ion means positively charged. Ultimately again depolarization will takes place. Okay, ultimately again depolarization will takes place. So to treat the so to inhibit the cell activity or cell depolarization, what will happen? We can also block the calcium channel, and these calcium channel are being blocked by verapamil and diltiazem, and also dihydropyridine. Dihydropyridine, verapamil, diltiazem, they are used to block the calcium channels. Next is renal tubule sodium channel. This renal tubule sodium channel is being blocked by aldosterone. So when the sodium channel will be blocked, the less sodium excretion will takes place. When the less sodium entry will takes place. When less sodium entry will takes place, the more exit or more excretion of potassium will also block. Less sodium entry, less potassium exit. More sodium entry, more potassium exit. So to stop or to decrease the sodium, to decrease the potassium excretion, or to decrease the loss of potassium, what will happen? We can block the sodium channels. So if we block the renal sodium channels, so the sodium entry will be less. When sodium entry will be less, the potassium excretion or potassium out will also be less. Ultimately it will lead to the less loss of potassium ions. Okay, and the block of sodium channel in the block of renal tubule sodium channel can be done by aldosterone. That's why in the case of hypokalemic patient, what is done, aldosterone agonist also given. Okay, next is along with the diuresis. Okay, next is ATP sensitive potassium channel. So what is ATP sensitive potassium channel? These are the different types of potassium. ATP sensitive potassium channels are also present in the different types, mainly in the case of, it is mainly in the case of glands, present in the case of exocrine gland. So in that case sulfonyl ureas will be given. For example, these sulfonyl ureas are also given to the to decrease the this sulfonyl ureas, sorry, 1 second, I am coming, wait a second please. Yes, so these ATP sensitive potassium channel are also blocked by sulfonyl ureas. Next, GABA gated chlorine channel. So GABA gated chlorine channel are blocked by picrotoxin. Next, glutamate gated chlorine channel. Glutamate gated chlorine channel are blocked by ketamine magnesium. Next are ligand. These second two are ligand gated ion channels. Second two means that GABA channel, GABA gated chlorine channel, or glutamate gated calcium channel. They are ligand gated ion channels, and the voltage gated sodium channel, voltage gated calcium channel. This voltage gated sodium channel, voltage gated calcium channel, renal tubule sodium channel, ATP sensitive potassium channel, they all are which type of gates? They all are voltage gated ion channels. Okay, so can you please repeat after me loudly? What are the different types of blockers? So which sodium voltage gated sodium channel can be blocked by anti-epileptic drug, it can be blocked by local anesthetic, it can be blocked by antiarrhythmics, it can be blocked by antiarrhythmics. Whereas voltage gated calcium channel can be blocked by dihydropyridine, verapamil, diltiazem, renal tubule. Next is renal tubule sodium channel. It can be blocked by aldosterone. ATP sensitive potassium channel can be blocked by sulfonyl ureas. Next is GABA gated chlorine channel. It is blocked by picrotoxin, and glutamate gated calcium channel can be blocked by ketamine. It can be blocked by ketamine magnesium. Okay. Next, number 2 are enzymes. So this enzyme is also a target of drug. So these enzymes are ultimately used in the case of different cellular effects. If we can block or inhibit the enzyme activity, then what will happen? We will see the less activity of the cell. we will see the change in the cellular response. So ultimately we can increase the activity, we can decrease the activity, or we can totally block the activity by using drugs. And what are the target? The target will be enzymes. Okay, so see, when the drug, it will bind to the receptor and the enzyme, they are, this drug can be for a substrate analog or they can be false substrate. So when they are substrate analog, they will show their action. When they are false substrate, they will decrease or inhibit the action. See here, in the case of substrate, when it will, when the drug is acting as a substrate analog and the enzyme will come and bind to the substrate analog, it will show its product. So when the product will form, cellular effect will be seen or cellular response will be seen. But when it will act as a false substrate, so when the drug is acting as substrate analog and the enzyme is inhibiting, at that time there is no product, and when there is no product, no cellular effect. When there is no product, no cellular effect. See, substrate analog, drug which is similar to substrate and inhibit the enzyme directly is called substrate analog. So these are similar to substrate and inhibit the enzyme directly. So these are the similar to substrate and inhibit the enzyme directly, and they are called substrate analog. Next, what are the false substrate? False substrate are the drug that get converted into fraudulent substance, and it is involved in the inhibition of the enzyme, and it is involved in the inhibition of enzyme. So drugs which converted into fraudulent substance, and it is involved in the inhibition of enzyme. For example, this is substrate 1 S1, it will go and bind with the enzyme and it will form substrate S2, then enzyme it will form substrate S3, then enzyme it will substrate S4, then enzyme it will make the product, or it will form the product. In that case we will see the cellular effect will be seen. But when the false substrate will come and bind to the enzyme, it will form such false substrate 2. When it will come and bind to the enzyme, it will form false substrate 3. When it will come and bind to the enzyme, it will ultimately not give the original product, or we will not get the final product, since the false substrate will, at that time the false substrate will be inhibiting the enzyme activity. So after that what will happen, we will not get any cellular effect. So cellular effect is not seen in that case. Okay, next see the enzyme and their blockers. So HMG CoA reductase, HMG-CoA reductase is blocked by statins. Next, dopa decarboxylase. Dopa carboxylase. Dopa carboxylase is blocked by carbidopa. Next is cholinesterase. Cholinesterase is blocked by neostigmine, pyridostigmine, physostigmine. Neostigmine, pyridostigmine, physostigmine. Out of that, physostigmine is the natural one. Next is monoamine oxidase, MAO inhibitor. So MAO inhibitor are chloryl, chlorgelin and meclobamide. Chlorgelin and meclobamide. Chlorgelin and meclobamide. MAO B inhibitor are selagelin. MAO B inhibitor are selagelin. Next is xanthine oxidase. Xanthine oxidase enzyme is blocked by allopurinol. Xanthine oxidase enzyme is blocked by allopurinol. Catechol O methyltransferase. Catechol O methyltransferase is blocked by telcapone and entacapone. Telcapone and entacapone. So catechol O methyltransferase is blocked by tolcapone and entacapone. Next, dihydrofolate reductase is an enzyme which is being blocked by trimethoprim and pyrimethamine. Trimethoprim and pyrimethamine. Next, dihydropterase synthase. Dihydropterase synthase is inhibited by sulfonamide. Dihydropterase is inhibited by sulfonamide. Next, protease. Protease is inhibited by secunavir, ritonavir. Secunavir and ritonavir, and these all secunavir, ritonavir, acyclovir, ganciclovir, rifampicin, these all are used in the case of antiviral drugs. Okay, rifampicin is an antibiotic actually. Okay, it is also called antitubercular antibiotic. So dihydrofolate reductase is inhibited by trimethoprim and pyrimethamine, whereas dihydropterase synthase is inhibited by sulfonamides. Protease is inhibited by secunavir and ritonavir. protease is inhibited by secunavir and ritonavir. Next is DNA polymerase is inhibited by acyclovir and citanavir. Next is RNA polymerase is inhibited by rifampicin. Next is vitamin K reductase is inhibited by warfarin. That's why they will show antagonistic effect. Which one will show antagonistic effect? Antagonistic effect will be shown by that warfarin and vitamin K. So vitamin K reductase is warfarin. Next, tyrosine hydroxylase and alpha methyl tyrosine. Tyrosine hydroxylase is blocked by alpha methyl tyrosine. Next is reverse transcriptase is blocked by zidovudine and diadenosine. Zidovudine and diadenosine. Next is hemopolymerase. Hem polymerase is blocked by chloroquine. Next, third target is carrier protein. So in the carrier protein, what will happen? Carrier protein helps in the transfer of hydrophilic molecules of one side of membrane to the other side. So when the hydrophobic membranes are lipophilic and they can easily pass through the membrane. Why? Because our cell membrane is made up of lipid bilayer and like dissolves like. So all the hydrophobic substances or hydrophobic molecules which are also called lipophilic, they can easily bind and they can easily pass through the membrane. Okay, but hydrophilic can't easily pass through the membrane. So to pass the hydrophilic membrane from one side of the membrane to the other side of the membrane, we need some carrier proteins. So it helps in the excretion of minerals and ions from kidney. It also helps in release the neurotransmitter in neuron. It helps in the gastric acid secretion. These are the action of carrier proteins. So they helps in the hydrophilic membrane to transfer from one side to another side. It helps in the excretion of minerals. It helps in the excretion of ion from kidney. It also helps in the release of neurotransmitter. It also helps in the gastric acid secretion. Okay, these are the most important points. Next we will see what are the carrier protein and what are their blockers. So the carrier protein like sodium potassium 2 chloride carrier. This is very important in the case of diuretics. You will find this. So mainly loop diuretics acts on this, and loop diuretics here it is written loop diuretics like furosemide, bumetamide, torsemide, ethacrynic acid. These all will bind to the sodium potassium 2 chloride 2 chloride carrier, and it will block that. When it will block, what will happen? The what it is called carrier protein will be blocked automatically, and when carrier protein will be blocked, cellular response will be seen. Next, sodium potassium and chloride carrier, only sodium potassium and chloride carrier, it is mainly blocked by thiazide diuretics. So what are the thiazide diuretics? They are chlorothiazide, hydrochlorothiazide, benzothiazide, and all this. Next is noradrenaline vascular carrier. What are noradrenaline vascular carrier or norepinephrine vascular carrier? They are noradrenaline and norepinephrine vascular carrier are blocked by reserpine. So what are they? See, this is your neuron. This is the last post side. So in this neuron, what will happen? Vesicles will be there. So what will happen? Synthesis of noradrenaline takes place from acid tyrosine to the L-dopa to dopamine, all those things. What will happen? This dopamine will be uptaken inside the vesicles. So this is the channel. This channel's name is noradrenaline vascular carrier. So in the noradrenaline vascular carrier, what will happen? The dopamine will be taken inside the vesicles. After that, inside the vesicle, what will happen? The the dopamine will convert into noradrenaline. So when this vascular carrier is blocked, there is no uptake of dopamine inside the noradrenaline through the noradrenaline vascular carrier, and this is mainly done by reserpine. So reserpine is a neurotransmitter blockers. Okay. Next, choline vascular carrier. Choline vascular carrier is blocked by vasamicol. Next, sodium reuptake, noradrenaline reuptake carrier. Noradrenaline reuptake carrier is blocked by tricyclic antidepressant. These are blocked by tricyclic antidepressants. Okay. Next, acetylcholine reuptake carrier. Acetylcholine reuptake carrier are hemicolinium. Next, sodium and potassium ATPase blocker. So sodium carrier ATPase is blocked by cardiac glycoside. So what are the cardiac glycosides? They are digitoxin, digoxin, and cogoxin. Next is hydrogen and potassium ATPase. Hydrogen and potassium ATPase is blocked by proton pump inhibitor. Next, number 4 are receptors. So what are the different types of receptors present? The different types of receptor are ionotropic receptor, G protein coupled receptor, enzyme link receptor, and nuclear receptor. So types of receptor we will study on the next lecture. Okay. So what are the different types of receptor? Ionic receptor, G protein coupled receptor, enzyme link receptor, nuclear receptor. So you have studied about alpha receptor, beta receptor, gamma receptor, not gamma receptor, alpha receptor, beta receptor, muscarinic receptor, and nicotinic receptor. These all are G protein coupled receptors. We will study that in the next lecture, and the mechanism of their action also we will study. Okay. Thank you so much.